Good afternoon, and welcome to the final webinar in the VHHA's 2019 High Reliability Organization Brown Bag webinar series. My name is Abraham Segrist, and I'm the Vice President for Quality and Patient Safety at the Virginia Hospital and Healthcare Association. On behalf of the Association's Center for Healthcare Excellence and the Virginia Patient Safety Organization, I would like to welcome all of our colleagues from across Virginia to today's webinar. Now in its third season, this monthly webinar series features successful strategies from Virginia hospitals and health systems promoting safety culture and high reliability in a variety of clinical areas. I'm glad to present today our colleagues from the Ballad Health System in Southwest Virginia and Northeast Tennessee in their presentation titled Fighting Hospital-Acquired Infections, Ballad's Health 30 and 90 C. diff Story. Our presenter today is Dr. Amit Vashish, Senior Vice President and Chief Clinical Officer at Ballad Health. After the presentation, we will have a few minutes for questions. We encourage you to submit questions using the chat box function in the webinar platform. A couple of quick housekeeping notes before we get started. And just give me a couple of seconds as I advance the slide. The slides were sent to everyone this morning that registered for the webinar, so they should be in your inbox. Just a reminder that the webinar is being recorded, and we ask that everyone dial in using their telephone option. All participants will be muted, and again, if you have questions, we encourage you to type them in the question box, which we will respond to at the end of the webinar. At the conclusion of the webinar, a feedback survey will be launched, and we ask that you take a few minutes to give us your feedback on today's presentation. So without further ado, I would like to turn the webinar over to Dr. Vashish, who will tell us about the efforts at Ballad Health to reduce and eliminate C. difficile infections. Dr. Vashish, the floor is yours.
Thank you so much, Abraham, and thank you, VHHA, High Reliable Organization Brown Bag Webinar Series, for giving me and Ballad Health the opportunity to showcase some of our work around zero harm and fighting hospital-acquired infection. As Abraham told you that I am the Senior Vice President and the Chief Clinical Officer for Ballad Health, and I also practice clinically. In fact, this weekend I was working at Johnston Memorial Hospital in Abingdon, Virginia. I practice across our facilities in Northeast Tennessee as well as Southwest Virginia. I'm dual boarded in internal medicine as well as in psychiatry, perform mostly hospital medicine role in my clinical practice. I'm excited to be here, and we'll get started straight away. Next slide, please. A little bit of introduction by way of what is Ballad Health. We were two legacy systems, Legacy Belmont and Legacy Mountain States Health Alliance, back in February of 2018 with the active involvement of the states and with the support of various community stakeholders, which included our chambers of commerce, physicians, team members, educators, everybody else. The merger was approved with state oversight. And we basically serve not only communities in Southwest Virginia and Northeast Tennessee, but also parts of Eastern Kentucky and Western North Carolina. Next slide. We have about 15,000, close to 16,000 caregivers or team members at Ballad Health. Of course, we, like any other healthcare system, we do have a volunteer board of directors, which are mostly comprised of local community leaders who live and work in this region and raise their families in this part of the world. Next slide. Ballad Health has about 21 hospitals ranging all the way from tertiary centers, which is our level 1 trauma center at Johnson City Medical Center, all the way up to critical access hospital. We do have inpatient behavioral hospital as well as the only children's hospital in our region. We have sizable outpatient presence, a big employed physician group, home health, hospice services, retail pharmacy, long-term acute care, facilities as well that are included under the umbrella of Ballad Health. Next slide. Little bit about the Clinical Council. Clinical Council was established the same time when Ballad Health was created. Originally, it was created as a mandate of the states that states wanted Ballad Health to create a core body of physicians dispersed across geographical areas where Ballad Health has its presence, dispersed across various specialties. And Clinical Council was basically tasked with helping the health system achieve what we promised to the Commonwealth of Virginia and the state of Tennessee, that we will improve the quality of care and we will lower costs at the same time. We will reduce unnecessary clinical variation. We're going to standardize our bylaws, credentialing, peer review process, so on and so forth. This would be a physician-led and physician-managed clinical council. We do have some administrative support, but the overwhelming presence is that of active practicing clinicians. Next slide. Next slide. So let me start off our journey in hospital-acquired infections. We started off back in the day with C. diff. I was the previous chair of the clinical council before I transitioned as the chief clinical officer. I still have administrative oversight of the Ballad Health Clinical Council. For years and years, I have been, for certain family reasons, in particular, what happened to my mother in a hospital, I have always championed the cause of zero harm. And when I took over at Ballad Health, we gave ourselves a task, an overarching goal, which is that by 2021, Ballad Health will be a zero harm top decile healthcare system. We started off with C. diff just because of the number of lives it impacts, the disease burden that it has. About 25% of all antibiotic-associated diarrhea, about 500,000 cases, 30,000 deaths annually per year, about $5 billion of extra healthcare costs for our hospitals because of C. diff. So we decided to tackle C. diff first. Next slide. So what our baseline data, which was mostly pre-merger data, was that between July of 2017 to March of 2018, keep in mind, we were only formed in February of 2018, so only 1 month of post-merger data, but basically this is pre-merger data. We had about 225 cases of C. diff during this period, 0.46 infections per 1,000 patient days. And we did a deep dive into what was causing some of these higher number of cases of C. diff. Of course, there was variation around our isolation signage across our different facilities. We were also concerned that we were ordering a whole lot more unnecessary, unindicated C. diff tests for our patients. There were times when patients had formed stools, they didn't have any symptoms. As many of you are aware, C. diff is a spore that is carried amongst healthy people as well. About 7 to 8% of people in the community, they carry C. diff spores. They are not symptomatic, and about 40 to 50% of people living in nursing homes and skilled nursing facilities have been shown to harbor C. diff spores. So we got to be careful about ordering tests. Then we also identified opportunities around hand hygiene, surgical scrubs policy, personal protective equipment, that we were not following the guidelines. Antibiotic stewardship, we were always very concerned that some facilities were doing better than the others, and there were opportunities for improvement. Next slide. So what the Clinical Council and our Infection Prevention Department, along with several others, multi-stakeholder involvement, we decided to come together, collaborate, and we came up with a very, very ambitious, what I call a big, hairy, audacious goal, or a stretch goal, which was we will reduce hospital-acquired C. diff by 30% within the first 90 days of the project. Next slide. Next slide. So approach started with, as I said, variation around the isolation signage. So our infection, you can see the picture below. The infection preventionists, they worked with our marketing team, and we designed a standard signage signs. And a lot of our team members and caregivers work in different facilities. Now, with one uniform isolation signage, they could recognize from a distance about rooms where we needed to have those precautions and isolation procedures in place for patients with C. diff. Next slide. We also launched a major educational campaign around getting our caregivers. That included physicians, nurses, even cafeteria workers, and everything. Starting with physicians, basically, what we were trying to do is to request them to order C. diff testing only when appropriate. We designed an algorithm we call the SCAN, which is you are basically checking the patients. Are they on sorbitol? Have they received contrast? Are they on any anti-constipation medications like Laxative, Colace, those kind of things? And have they been started on new tube feeds? And once that algorithm gets activated, if I order a test, like this weekend, I ordered a test on somebody, and basically they said, did you know the patient was started on pig tube about a couple of days ago? And I was like, okay, maybe I ordered it inappropriately. Let me cancel that test. So we put those algorithms into place. We bolstered our education around antibiotic stewardship. We did tons and tons of awareness drive, mindfulness drives around hand hygiene. And we also kind of try to empower through multiple levels of messaging for people not to get defensive if somebody asks you to wash your hands. Maybe a nurse noticed a physician entering or vice versa. So to respond positively. And of course, we focused a lot on the other aspect, which is personal protective equipment. Next slide. So in addition to that, we launched a big marketing campaign. I did a video with our CEO, Mr. Alan Levine, and our chief clinical officer at that time, and our head of corporate director of infection prevention, Jamie Swift. We made a good video around what we were trying to do around C. diff, our 30 and 90 campaign. We designed tent cards, put in tons of screensavers, flyers, memos, you name it. And we did some other creative things as well around Dress to Remember kind of events, and I'll share a few pictures in a little bit. Next slide. This is one example of a tent card that we put in all our physician lounges, which I talked about the SCAN algorithm, just a little bit of awareness around C. diff, and they were very strategically placed on the tables and such places. Next slide. This is what the creativity part I was talking about. People wearing things that resembled poop, stools, all those kind of things. We did a lot of campaigns around that, held a lot of events at strategic places at multiple hospitals, and our infection prevention team really took a lead on making people aware, our caregivers aware of the importance of the C. diff drive. All right, next slide, please. When we started on our C. diff, our corporate pharmacy director out of Johnston Memorial Hospital in Abingdon, Virginia, reached out to us. This was the beauty of the whole thing, and basically they said that, I know the infection prevention personnel, doctors, nursing, everybody's involved in this thing, but here is where the pharmacy can help. And they built in, an alert system whereby the pharmacist would be alerted to every time we would place a C. diff order in the EMR, and they would basically run the SCAN algorithm for us. And soon thereafter, patient, the physician or the advanced practice provider would receive a notification that probably you ordered a test, but just so you remember, the patient, this is part of that algorithm, and you should consider not ordering that unnecessary test. But physicians still had the autonomy to continue the C. diff testing. In that case, we just made a note, and the chief medical officer of that facility or that market would check was it appropriate or not. But we never forced anybody not to do it if they felt in their clinical judgment they needed to go ahead and do that. So a pharmacy also notified infection prevention for follow-up with the physician when physician could not be reached. So we created a multiple layer of defense around the C. diff drive so that the Swiss cheese effect did not happen. Next slide. Next slide. Yeah. So we got some very remarkable results. In the 3 months monitoring period after launching the 30 and 90 drive, we experienced about a 41% decline in the rate of hospital-acquired C. diff compared to our baseline data. And of course, it was a multimodal, multi-stakeholder strategy, but our education, marketing, awareness, mindfulness campaign really paid off. And we were also looking at places where the processes broke down, did robust root cause analyses around that. So next slide. The next, at Ballad Health and within our legacy Mountain States and Wellmont facilities, we have all realized that we were good at driving some results, but extremely poor and sustaining the results. So we doubled down on our education and antibiotic stewardship, hand hygiene, all those kind of things. And we have continued to sustain our success. Not only have we sustained, we have actually improved upon our success. If you see, we till date, we have experienced about a 43% decline in our hospital-acquired C. diff cases. Remember, the initial campaign was we would target a 30% reduction in 90 days. So over the course of a year and some more, we have sustained a decrease of 43%. And I think we can still do better. We always see C. diff cases that creep up that should not have creeped up and everything. So we take them very seriously. Of course, there comes a financial burden of the infection, about $18,000 per case of C. diff. And we did a cost analysis, and basically all our efforts and activities have resulted in savings of over $2.3 million for Ballad Health. So we have tried to improve on the whole value. It's not just quality, it's about cost. The whole value equation benefits when we work around those things. So next slide. So moving forward, there were some lessons that we learned. And what we are trying to do is we have rolled out our MRSA as well as CAUTI, catheter-associated urinary tract infection campaigns, where we are trying to replicate the 30 and 90 kind of results. So basically, one C. diff initiative has resulted in the same, I call it the 30 and 90 series, and we are talking about which one is our next 30 and 90. So currently, we have just started work on our CAUTI as well as on MRSA 30 and 90 initiatives. What that also did was not only was it very specific about infection prevention or hospital-acquired infection, what that has done is that has also created a very close collaborative relationship with not just infection prevention and the clinical council, but between pharmacy and the clinical council. And what our physicians and physician leaders have come to realize with the example of C. diff campaign is how when multiple stakeholders, not just physician, not just nursing, not just pharmacy, not just infection prevention, when they come together to collaborate, the results are really remarkable than the sum of the individual parts. So of course, we continue to tackle, we have installed hand hygiene sensors and in the process of rolling it out to multiple other facilities. And we are working with our mid-staff services subcommittee of the clinical council to devise some bylaws around compliance or lack thereof with hand hygiene, personal protective equipment, as well as surgical scrubs, so that there be consequences for clinicians who choose to disregard best practices. Overall, I think C. diff has just been a wonderful starting point for our bigger zero harm, high reliable organization journey for Ballad Health. So that's that is that is pretty much it. I would like to welcome any questions, if any, but I would like to thank you for your time and for giving us the opportunity at Ballad Health to share our success story.
Dr. Bashish, thank you very much, and many thanks to you and your colleagues at Ballad for, one, sharing your story with us, but also the clear impact you've had on the healthcare of the population down in that part of Virginia and Tennessee. Not only the gains you achieved, but the gains you've been able to sustain over time. As we mentioned at the beginning of the webinar, those that are listening, if you have a question, please feel free to type it into the question box, and we'll be glad to read that out. And as we wait for questions, we have no question at this time. A comment that says excellent presentation. So let's maybe give folks a few more seconds to put in a question. I actually had two questions. You've already addressed one of them, but I was curious as to whether you all experienced any sort of translation of results to any of your other categories of healthcare associated infections. But you made reference to beginning to work with MRSA and CAUTI, but I didn't know if you guys had seen any preliminary indication that this is already translated over to other categories of HAI.
Yeah, that's a great question. So one of the other things that we have learned is that when you're going to launch some of these things, you gotta jump right in. You gotta work on your processes, lay the right foundation, do your homework, do your education, marketing, whatever. But be prepared for failure as well. So what I did not tell you was that we are going through almost our second iteration of the CAUTI 30-90 kind of series. The first time when we started, we had some faulty product around the urinary catheter, which caused a temporary jump in our infection, so we had to abandon that. So we did a further drill down. We got the good products, recommendations in place, and everything. The results over the last, I would say, month to a couple of months are promising. They are not 30% yet. We still have our challenges, but we are definitely seeing a decline in the CAUTI process. We also put in four other points to reduce the CAUTI, which was basically reintroduction of education for nurses in their training modules, CHG bathing. What we also realized in CAUTI when we do the drill down was day 4 and beyond patients were our biggest concern. And then there was the belly button to knee cleaning twice a day for those kind of patients. So, and we are putting in a little bit of build in our EMR around the urinary retention protocol. So I'm very optimistic that within the next 3-4 months, I think I would say I may be a little wrong here, about 14% or so over the last month and a half. But I'm positive with this 4-point program that we have for CAUTI, we will be able to see some pretty dramatically improved results. MRSA, we just started last month of that, so we don't have the data for the MRSA.
Well, we certainly wish you all the success in both of those initiatives, and perhaps next year this time we'll have you back on to share the results of those initiatives.
Absolutely.
One of the things we always like to inquire, which is really good for learning for others, is if you look back at the program, are you able to identify like what perhaps the most significant barrier was in terms of getting the initiative started, and how you all were able to address that barrier? So as you look back at the work on CDF, was there a particular barrier that was pretty challenging?
Yes, and people can think, oh, maybe hand hygiene was not this. We can drill down to the process. Probably we can, probably we can't. But I will tell you the biggest barrier, and then this is now the psychiatrist talking with you guys, is the biggest barriers were kind of the cultural barrier. I would say hierarchical barriers. For example, physicians not used to being called out once they order a test or once they enter a patient's room without doing hand hygiene and everything. So initially, I used to field a lot of phone calls when the scan process was activated that has Ballad Health now started to tell physicians how to practice medicine and everything. And what I requested our infection prevention and nursing personnel was I gave them my number. Since I practice very, very actively, I would be able to answer their questions like from one physician to another. So I fielded a few angry phone calls and everything. So that was number one. Number two was the clinical council. That was a piece of beauty because all these initiatives that were rolling in were not Dr. Vashist's, creation or anything. Those were endorsed by the clinical council of Ballad Health, comprising of 50 plus clinicians. And practicing clinicians, not just token physician leaders. So that carried a lot of weight as compared to some of our previous initiatives, which were somehow construed as the CMO wants to do it because the corporate department wants this to be taken care of. This seemed to them that this recommendation was coming right from the trenches.
Excellent. And we do have two questions that we've got in. I think one you may have already alluded to, but it says, which key stakeholders were the most challenging to get on board? And perhaps your comments just now might respond to that. But any other stakeholders that were challenging, or what do you think the physician group?
So two stakeholders stand out, and of course, this is not rocket science. And for very different reasons. I would say number one was physicians, just because we are used to practice a certain way. All of a sudden, we are trying to put in 10,000 evidence-based guidelines, and all those kind of people calling them out about certain unnecessary stuff. The second was the nursing staff, but not because of what they were, because of the perceived, a sense of that if they're going to call out somebody, it's going to lead to a perceived confrontation. To create that culture of calling out justifiably. So we had to work on that, a surgeon can get angry, this surgeon can get angry when he's called out. We had to basically put in a lot of reassurance in place that we will take care of that if yelling or screaming, some kind of that behavior happens.
Wow. And the second question appears to be sort of a process question. It says, 30 to 90 is a great example of rapid cycle change. Congratulations on your results. You mentioned doing your homework. How long would you say the prep period was prior to launch?
I would think at the most, I'm thinking, well, it's been a while since we started. I would say no more than 40 days, because when you do the rapid cycle management homework, you really have to create a burning, John Carter's 8 stages of change, which is creating a sense of urgency and all those kind of things. So in order to be successful, we really had to delve all of our resources in and jump in 100%. So a lot of simultaneous processes were happening. When we were shooting videos, we were designing our tent cards and everything. That's where the marketing, everybody came in. All to help us, a lot of corporate support from our CEO and everybody else, but no more than 40 days, since we just wanted to, it was kind of, maybe it's a poor equivalent, but it was kind of a shock and awe. And we just wanted to jolt the organization in a positive way, that even if we do less time and everything, we can still do our homework well enough. We were starting as a startup company called Ballad Health. We needed some early success. So we went really quick on this one.
Excellent. Well, that appears to be our final question from our audience. So I would like to thank you again, Dr. Vashist, for the wonderful presentation and for, again, sharing the Ballad story with the rest of our hospitals across Virginia. And for our audience, remember, this is our final webinar of 2019. We will soon begin to solicit ideas and presenters for next year's High Reliability Organization Brown Bag webinar series. So if your organization has seen success in the area of quality or patient safety and would like to share with your colleagues across the state, certainly feel free to reach out to me or any other member of the VHHA's Center for Healthcare Excellence team, and we'll go ahead and get you on the schedule. We thank you all for being with us this year. Thank you again, Dr. Vashist, for being our final presenter of the year. We wish everyone the very best for them and their families for the upcoming holidays. And we hope that you'll join us in January when we'll begin the 2020 webinar series. And please save the date on your calendars for our annual Virginia Patient Safety Summit, which will be held in Richmond, February 19th through the 21st. And we'll be sending out more information to everyone between now and then about that event. So again, thanks everyone for joining us today. And again, Dr. Bashir, thank you very much for your time. We hope you all have a great afternoon.
Thank you. Bye-bye.
Bye-bye.